This is She's on Call, a weekly show hosted by ENT specialist Dr. Sujana Chandrasekhar and General Surgeon Dr. Marina Kurian. They'll be joined by guest experts to discuss an array of newsworthy medical and health issues. You're invited to ask the doctors anything. The physicians and their guests' views are their own and do not represent any institution. Please contact your doctor for any personal questions. Please hit share and join us live on Facebook, Twitter, and YouTube at She's on Call, hashtag She's on Call. Please welcome our hosts.
Hello, I'm Dr. Sujana Chandrasekhar. I'm an ear, nose, and throat surgeon with offices in New York City and Wayne, New Jersey.
You didn't even try and mess me up this time.
I didn't.
I'm a little upset by that. I'm Marina Kurian. I'm a general surgeon in New York City. I also happen to do weight loss surgery and other minimally invasive surgery as well. And
so I'm going to mess you up.
Okay, go ahead.
Because Thursday I worked with a fabulous scrub tech, and she saw your picture on the show card, and she's like, "Oh my God, your co-host is my beautiful surgeon. You're doing surgery on her in February."
No, you're not messing me up. I know where you work, dude. But the scrub techs are always so amazing. They really make our lives better. For those of you guys that don't understand that, what we do is we're operating and we need assistance, and not just assisting in the surgery, but people handing us our instruments, making sure we have everything that we need, giving us what we need, not what we ask for sometimes. And our scrub technicians, we call them our scrub techs, are the ones that do all that, and they totally make our lives completely easier. We have a great show today. It happens to be the last one of 2021. I have been traveling too much, which is why I have not been able to be on the show with Sujana. But our last show is a spectacular one. We're going to be talking about healthcare in vulnerable populations.
And we have two wonderful guests. We have Dr. Sapna Kudchadkar, who is a pediatric intensivist and anesthesiologist at Johns Hopkins University in Baltimore, Maryland, and Siobhan Westcott, who is an MD MPH, so she has a master's in public health. She's director of American Indian Health at the University of Nebraska Medical Center School of Public Health. She just got a full professorship, and I'd love to hear her take on the name of her professorship. We have a lot to talk with them about, and please share and like and follow and alert your friends, because we're going to be talking about a lot of things with these two wonderful guests.
Yeah, it's very exciting. And just even the back show chat was really fantastic. Unfortunately, we still have to talk about COVID, you and I. And there's some meme going around that says all the Greeks are like, "What do you mean you can't say?" So I asked my Greek colleague how to say it. Omicron.
That's right.
Yeah, right.
So Omicron is written as a small o, and omega is a big O, because micron and mega. So I'm like, oh, that's easy. I can figure that out now. So this is Omicron.
Wow, I didn't even know that. You threw me right there. That one. Otherwise, I'm always ready for your stuff, But this time you got me. I had no idea. That is so simple. My goodness. My Greek colleague did not tell me that. Now I'll be like, why didn't you say this? And I'll be like, because it's so obvious.
Right. They're like, what?
Exactly. So let's get into it a little bit. We can look at. Let's talk a little bit about coronavirus. This is worldwide. The number of cases, so almost 300 million worldwide. There are over 5 million deaths, but the good news, the majority of people recovered, but it's still such a crazy 2 years coming up on, right, that this has been going on. And are we ever going to be out of this? And I think that we can. The interesting thing, the people talking about Omicron, is that it is not as severe, but because of all the mutations on the virus, it has, we have a slide on this too about how Omicron is doing in terms of the vaccines and the boosters. But we are seeing a rise in the number of infections because it's sort of much more contagious because of all the mutations that it has.
Right. So when we look at the data from nursing homes, so some of our most vulnerable people, we see that the rate of increase in cases in nursing homes in unvaccinated people is just rising exponentially, rather astronomically. If they've been what is called fully vaccinated still by the CDC, which is either one Johnson & Johnson vaccine or two of the mRNA vaccines, which are Pfizer and Moderna, they still unfortunately have a high rate of infection because Omicron is able to elude just the two vaccine regimen. But if they get vaccinated and they have a booster, we are not seeing cases of Omicron in these very vulnerable people. So it's really, really important that if you've been fully vaccinated, so-called, that you actually get a booster, which should be the optimal vaccination regimen at this moment.
Yeah,
And
we have another
tomorrow,
slide, right? We have another slide looking at that
yeah,
for what's happening per 100,000 people, and you could see if you're not vaccinated, the likelihood that peak, that curve upward, it's just still rising. That's why it hasn't peaked yet. And but you can see what happens when you have the vaccination. So this was just another way of looking at it. And I think, you know, what you were talking about is something that Neil Parrick, one of our producers, saw on Twitter. It's a whole thread line from Bob Wachter, and it kind of really breaks down the immunity and I think in a helpful, very layman's kind of way.
right. So he talks about it really does break it down. It says, well, if you've been vaccinated and you have a booster and you had COVID, and hopefully you're doing well after that, you are the most protected. If you are vaccinated, fully vaccinated, and a booster, which is optimally vaccinated, you're really well protected. A little bit less than if you had COVID, but good news, you didn't get COVID. If you only have the two vaccines or the one J&J, you're actually much less protected from the Omicron variant. And if you've not been vaccinated, you are unfortunately the people who are filling up our hospitals and our ICUs. And you are also the vector for the mutation of the virus. So please, please, please get vaccinated and get your booster and be optimally vaccinated. I have the distinct pleasure of being on Sri Srinivasan, who is our third co-executive producer of this show, being on his COVID call-in show tomorrow. It's a talk show, again, produced by Digimentors like this show is. It's his 294th COVID-19 show, and he has Dr. Abdi Mohammed from them, who is in fact the Omicron expert of the world, who's going to be talking to us and teaching us at 12 o'clock Eastern tomorrow. So if you guys get a chance, tune in live or watch later.
And you're going to be on.
I'm going to be on, and you're going to be operating because you're on call.
Yeah. No, I'm not going to be on. Well, you're going to be on. That's just perfect. It's going to be just great. The two of us on, we try and take over the show. You know, so this, what does this mean for everybody? I mean, like, everyone is so burnt out from literally masking and COVID. We are too, but I still like to wear my mask now. Like, I was in Montana outside, not very many people around me at all. And I kept going like this. Okay. And my friend's like, what are you doing? I'm like, it feels weird. I don't have my mask on. And it just,
the air on your cheeks feels weird, right?
Usually, you know, what I've realized now with all this masking is it's much warmer in the winter when you wear your mask. Just saying.
It is.
But our travel is affected again, right? And so we have a couple of slides on travel and what's going on. And so this is, most of the countries are still open despite the Omicron, you know, variant, and most require some pre-arrival testing in addition to the vaccination card. So I had gone to Europe a couple of times, and I had to show my Vax card as well as I didn't have to get a test when I got there, but certainly coming back to the US, you have to do it. And it used to say within 3 days, but now it's within 1 day of departure, you have to have the test. And I think everybody is used to that. And you could see in New York City, they have all these test stations set up, and they are overwhelmed. The lines are so long because people are traveling and they want to get tested before they hit the road.
Yeah. I think, we talked about herd immunity and defeating it. I think now we're talking about how to live with it. Just do your part, guys. It's so easy to wear a mask. My office in Manhattan is right by Rockefeller Center. It's throngs of people. So just wear a mask, even if you're outdoors, if you're with a large group of people, get your vaccine, get your booster. Be careful, be safe, and care about your neighbor. We are live on Facebook, YouTube, and Twitter. We're on Shree's LinkedIn page, WBAI 99.5 FM and WBAI.org carries us on Mondays from 2 to 3 p.m. Thank you. And we have a podcast, so please like and share and tag your friends and have them follow, because we are going to meet our guests.
Yes. So Dr. Sapna Kudchadkar, who is a pediatric intensivist and anesthesiologist at Johns Hopkins, and Dr. Siobhan Westcott, who's Director of American Indian Health at University of Nebraska Medical Center, School of Public Health. And we're so excited to have both of our guests join us. Yay!
Yay!
So welcome to the show. We really are excited to have you on. You are our 115th and 116th guests. And
they're not just numbers, though.
They're not just numbers. They're way more than that number. And you are on our 59th show and our last show of 2021. So let's dive right into it. So Siobhan, Dr. Westcott, you've had a really cool journey to where you are. So can you talk to us a bit about how you got to where you are and how you determined what your focus would be now?
Okay. Well, I'll say my family's from Alaska. We have a small cabin, about 400 square feet, with running water, which means we have indoor plumbing, but if the well goes dry, then you had to haul water. And I'll skip a few steps, but then I went to Harvard Med School when I was 35. I was the oldest in my class after starting and enjoying a really wonderful public health career. And now I'm back in public health, and I'll say one of the things that drives me is that when I was 4, my mom took me with her. She was going to a Harvard master's program, and she enrolled me in some preschool for Harvard affiliates. And on the first day, the other kids beat me up, because that's what you do with an Indian. So, racism is, a bit a part of my life as long as I can remember. So my aim in life is to reduce racism.
Wow. Really? Some kid just looked at you and decided, oh, you're an Indian, I get to beat you up?
Plural. Yes.
What?
That's dreadful.
I'm so sorry. We were talking before the show. So we have 4 Indians on this show. 3 of them are similar and 1 is different, but all 4 of us are the same in that we have accomplished much of what we dreamed we would accomplish, and that dream changed at different times in our lives. But I was telling Siobhan, I'm Indian from South India, and so many times I was asked what tribe I'm from. And I'm like, really? And I was also asked if tigers roam the streets. And I'm like, what are they, vegetarian tigers? Like, what is this ridiculous question? So Sapna, tell us a little bit about you.
Yes, well, I think I have some similar stories to share, Sujana, as you did. I grew up in a small town in southern Illinois, so there weren't many people around who looked like me. And, it was like of the population of 20,000, the 5 Indian families that, were in this little community would get together on the weekends, et cetera. So that was my source of community. Like Siobhan, I'll skip a few steps and, went on to medical school in Chicago, at University of Chicago, and then ended up at Johns Hopkins for Pete's residency. And this is 18 years ago. And I full on was expecting to be an absolutely wonderful general pediatrician out in the community, taking great care of kids. But then I went to the pediatric intensive care unit, and it was clear that high acuity situations that were often unpredictable really was my passion. That's what I was good at. And then I spent time in the operating room with amazing surgeons like yourselves. And then I said, wow, I really want to be an anesthesiologist as well. So I spend half my time as an intensivist, half my time as an anesthesiologist, taking care of only kids, because kids are amazing. And the rest of my time I spend focusing on optimizing outcomes and survivorship for critically ill kids, because as we'll probably unpack a bit more later, kids have long lives to live. And even though their mortality rates are much lower than critically ill adults, the impact of critical illness can be very significant for a very long time.
Yeah, so we had a slide, Sapna, on what pediatric intensivists that I got, for one of your websites. But it's a lot of, for those of you who've never, thank God, had a child either in the hospital, but in the pediatric ICU, it's a tough place to be, but a great place to be. The passion, the just overwhelming, intense, but excellent care that is delivered for these children by the doctors, the residents, the nursing staff, everyone there, to even the people who are, the most important people in the hospital, who are cleaning all the rooms and making sure that all the things that need to be done are done. I want to say it's a passion project, but it's just, that's just the way it is. And no one doesn't care. Everyone cares. Everyone cares about every little thing. And it's just, as a surgical resident, we go into the pediatric ICU and you just feel that. You always, same with the neonatal unit. That's a scary place to go when you're a resident, because the nurses are like, what are you doing here?
Yeah.
That's where the tigers roam, is in the NICU.
What's that?
That's where the tigers are, and it's the nurses.
Yes,
they run it, and they're like,
right.
Stay away from
Exactly.
me.
Yeah,
Well,
they're very protective of their charges, right? And the stupid little ENT resident or surgery resident coming in better hold it together.
Toe the line.
And Marina, I just want to say thank you for putting up that slide. I think, pediatric intensive care struggles a bit with a public knowledge challenge, right? So I think everyone has some awareness of what a neonatal intensive care unit does. There's a lot of attention given to neonates and preemies for very good reason. But something happens in between the ages of 1 day old up to 18. Not a lot of people know what happens in a pediatric ICU because the breadth and the heterogeneity of our patients is so wide. Trauma, oncology, transplant, all the things you saw on that slide. But we take care of a lot of patients, and the vast majority of sick kids who are critically ill are in the PICU. So I'm really glad that we have this opportunity to talk a bit more about this really incredible profession.
So thank you, Sapna. Just like a lot of people, thankfully, have not experienced and don't understand pediatric intensive care, a lot of people are confused as to the correct linguistics for the indigenous peoples of, let's say, North America. Let's just keep it in North America for the moment. So Siobhan, I think that the beauty by which language and nature are intertwined in indigenous people, in Native American people, in American Indian people is extraordinary. Can you explain to us what your project is about this and what we should learn?
Sure. And I think we have a slide of the in-process beadwork that I'm doing for a paper. So I've had reviewers similar to, being asked if you're clearly East Indian, but what's your tribe? I constantly get referred to as not Indian because of my name. And when I send in papers, they say, oh, clearly you've never worked in an Indian health service or cared for natives because you didn't use this term instead of that term, or explain this particular very complicated arrangement with the Indian Health Service and the tribe, which you couldn't do because of the word limit. So I'm being proactive. I don't take things personally. You've got to just keep moving on, say, what's the problem? How do we fix it? I know that's also a very surgical approach. So for that issue, we're doing a study where we're tracking the trends from the 70s to now in PubMed publications for what terms have been used. And we had to actually keep it just to the US because when you get into Canada, it's very complicated. So, but just in the US, and then we're making this figure and it's going to be beaded because people don't understand the relationship of the terms. And so American Indian is one category, and that's actually preferred by the federal government. Alaska Native is a legally distinct group. We actually are just celebrating the 50th year of the Land Claim Settlement Act. And then Native American includes both those groups. And then Indigenous could be also any of those groups. But all of the terms are poor. And we were chatting beforehand and joking, you know, we have to do some Indian fusion because American Indian is based on a 500-year-old mistake, and yet it's still the preferred term of the federal government. So I wore my Indian coat so we can have a true fusion here of the Indians. But that's, you know, none of the terms are ideal. And there are terms that tribes prefer or Native people prefer. So, you know, try and work with that. But it really is groundbreaking to at least look at what the trends are and try and figure out some recommendations for what to choose when.
It's so complicated because you don't want to say the wrong thing. But it's nice to know that in this instance, none of those things are exactly wrong. They're just not completely correct.
Yeah, pick the least worst of the bad.
Yeah. And you see that in your title too. You're director of American Indian Health, right? I mean, so it is, I guess, prevalent. I want to switch gears just a minute and let's also talk about the vulnerable population of kids. I found this study, Sapna, on pediatric ICUs and children and mortality. So we have a slide on that that we want to pop up. So can you talk about this a little bit?
Absolutely. So, you know, even though children have quite low mortality rates, fortunately, because the vast majority of children, as you can imagine, are a bit healthier, and then they have, you know, whatever, whether it's an injury or a new diagnosis oncologically or anything else, our mortality rates are in the range of anywhere from 2 to 3% is the average, but that varies depending on where you live, et cetera. And I think the study that you put up speaks specifically to, you know, neighborhood poverty, for example. And, you know, I live and work in the Baltimore City area. This study, I believe, came out of Cincinnati, but essentially focusing on specifically what happens when neighborhood poverty impacts actual mortality in the hospitals that are taking care of these patients. And so there's a lot that we have to unpack. And I think we'll talk about another systematic review that was done later, kind of compiling all of the data that's out there. But the bottom line is we have a lot of demographic and socioeconomic data that is associated with outcomes, but now we don't really have much in terms of interventions yet. And so I think that's like the big box that we have to unpack now in terms of like, how do we, even though 2 to 3% seems really low, it's not low enough. And obviously then there's all of the issues with the children who survive after they leave the hospital and what happens to them.
Right. Especially, I think one of the things about poverty and that neighborhood aspect is really it's the underlying care to start, right? And
exactly.
You know, our key, as I think all of us as physicians would say, that prevention is the most important thing. I mean, I love to operate. I'd give it up, man, if we could, you know, prevent, right? Like if we all focus on prevention, that would make such an amazing difference, and it would improve world health.
What I often say is that, you know, if for some things, you have to come to the pediatric ICU, i.e. if you have a major scoliosis surgery or something like that. Those are planned admissions. We know what to expect for the most part, and we take the best care of them possible. But for all these other diagnoses that we see kids for example, critical asthma, underlying things that we could have done a better job preventing, by the time you get to my pediatric ICU, it's too late. We've lost a major opportunity for prevention out while the kids are living their lives, trying to have the best childhood possible. Then they come to us, and it takes several steps backward every single time. And that's what I don't want to see these kids in my ICU anytime, because we're doing such a great job of preventing these critical diagnoses up front.
You talked about wanting to be a general pediatrician in the beginning, and I think that prevention of entry into the pediatric ICU begins every single time the children's pediatrician says, "Oh, and when you ride your skateboard, what do you have on your head?" And "Oh, what do you think about smoking?" And sort of really engaging the children in conversations to limit their exposure to bad things. We have people watching from all over. Thank you so much. David Shapiro, Ellen Austin, Rose Horowitz, who's also live tweeting, Laura Silverman, Sandra Blake Lefkowitz. I have to tell you, Siobhan, a couple of our viewers were just, as we were, completely shocked by that story. Miriam Berkeley, Divya Markande, who says she's so excited to see all these Indian people. Are you excited to see all four of us? Janet Weeks is happy for the nursing shout out. Oh my God, if the nurses don't know how much we love them, man, I don't know when they're going to know.
Love all around.
And we've had two former guests on the show, Modele Uguniyi from Atlanta and Monica Verduzco Gutierrez from San Antonio, watching, and thanking you both for all the work that you're doing. Modele actually made a point last week that when she was in training at Hopkins, having lived in Nigeria, she looked right outside the ivory tower and, talking about poverty, could see something not very different from her experience in Nigeria. So I think we have a long way to go, and until we identify these things, we're not going forward. Siobhan, there is an entire Indian health service that is really dedicated arm of government. It's an arm of the Health and Human Services to care for Indian American, Native American, indigenous populations in the United States, near or close, at or close to where they live. Can you talk to us about that and what we can rely on there for ongoing healthcare to these populations?
Sure, it gets very complicated very quickly, so I'll try and keep it simple. You do have to be an enrolled member of a federally recognized tribe, and that gets very political very quickly. But it is the only race in the U.S. that has a birthright to healthcare. So the Indian Health Service, though a lot of people don't know, its origin is actually in treaties with tribes that mainly written in the 1800s, and healthcare was included. And I'm going to exaggerate here for effect, but healthcare in the mid 1800s wasn't much. There wasn't surgery yet. There wasn't even anesthesia. There was not even blood transfusions, IV fluids. So it was very limited, but it was included in these treaties in part because the federal government wanted the ability to isolate and quarantine Indians in cases of outbreaks. So it's coming full circle now with the pandemic, because the Indian Health Service has actually led the U.S. in vaccine response. It's an organization that's been very good about vaccines in general, but when it came to especially needing very cold freezers, not just regular freezers, but the super cold freezers, which you had to get to rural areas, the Indian Health Service figured it out, and it's among there was just a New England Journal article published on that. And the Winnebago tribe here in Nebraska has done spectacularly well. I mean, this is a true success story. I mean, there's still pockets where there isn't as much. Some tribes aren't quite as successful, but in general, the Indian Health Service has done proud.
So I wonder if we can switch to peds again. So we have maybe coverage. You know, I had the joy of doing a 2-week rotation actually at the Indian Health Service in Phoenix, Arizona as a resident, and we actually flew out to, let's say, the northern edge of the Grand Canyon to really, really remote tribes, and thinking about getting super frozen vaccines to the groups of people who live out there, you know, on the reservation is remarkable. One of our viewers asked about universal health care for children. So Sapna, can you talk to us about how kids are covered when they get sick, and what that means if they need extensive care, like in the intensive care unit?
Yes, that's a very challenging topic to unpack, as you can imagine. But you know, the bottom line is, kids do get the care that they need. But the way that our healthcare system is set up, and obviously in Maryland, we have very specific rules surrounding you know, children's healthcare and insurance compared to other states. So across states, it's very different. It's so complex, and you know, it's just this need to simplify so that the preventative aspects, I think that's where we lose, right? So, you know, when a child shows up in my ICU, we do what we need to do to make sure they survive to the best of our ability and to optimize their outcomes. And we'll talk a bit about the disparities surrounding that may be unintended, A, and B, that need to be addressed. And I'll talk about this in a moment. But really, the bottom line is, if we're not getting children universally protected from the preventative aspects, making sure that every child gets the preventative care they need, gets the vaccines that they need, all of the things that we lead to a healthy childhood, including the basic tenets of healthy childhood, right? Good nutrition as the key, that they're getting good sleep, and that they have shelter, they have electricity. These are the things that make the biggest difference. But the problem is, like, we don't see that. We see there's so many amazing people doing incredible work on the ground in the communities, but we don't see it. I don't see it until they end up in my ICU. And again, by then it's too late. So in the ICU, the insurance issues don't play as much of a role, but I do believe it plays a significant role in the prevention. And what we found specifically in this study that was led by Hannah Mitchell and Nader Yehia, that was actually a large review of all that we have out there with regards to evidence for racial, ethnic, and socioeconomic disparities, is that there's a lot of isolated papers covering this topic. And as you can imagine, a lot of them are geographically based, single center. And what they observed was, for general critical care issues, it's a mixed bag in terms of disparities. However, there's certain areas that are very interesting and came out, which is out of hospital cardiac arrest and outcomes surrounding that, and how they relate to disparities, as well as things like oncologic diagnoses. And again, coming back to asthma, right? That is the most bread and butter pediatric diagnosis that we can have an impact from the beginning, so that it's mild intermittent asthma versus severe persistent asthma. So lots to unpack, but you know, it comes back to, in the community, you know, if we have higher rates of critical illness and trauma and all the things, we're not giving anticipatory guidance about guns, about helmets, about not riding an ATV. You know, there's so many things I see in the ICU that break my heart, because they didn't probably have a chance to hear that before. And then, of course, on admission, what happens in the hospital, and then this whole issue of post-intensive care syndrome. It's post-intensive care syndrome in pediatrics. PICS-P is the name. But now we're learning about all the ramifications of what happens after they're out of my ICU. So
out of your control, Sapna. That's what I heard.
Exactly. It used to be out of sight, out of mind, right?
Oh, yeah. You think it's a win when you get them out. But you know, we know this for I mean, a few papers on gun violence in kids, and the likelihood of their mortality increases even if you win in the hospital, if they go back to the community or to their situation. One of the things that struck me while you're talking is, you know, yes, about prevention, but when you started talking about good food but having a safe and protected home environment is so critical, right? That I think a lot of illness comes from the fact of uncertainty and not having that security. And then it of course impacts your mental health, your physical health.
And I think I completely agree. And the hardest part of my job, I'll be very upfront, and I think my peds ICU colleagues, nurses, interprofessional staff would all agree, is the non-accidental trauma. So, that comes back to a home where children are protected, and to see an infant, toddler come in as a result of child abuse it's heartbreaking. And we deal with a lot in the ICU, you can imagine, but you feel completely helpless in those moments. So there's so much we can do. There's so much that we're probably missing. So that's why we need everyone's help to figure this out, so we can decrease the rates of these things that really could have been preventable.
I'll add, what I learned about peds in med school is that if you can't cure it with time, Tylenol, albuterol, amoxicillin, or prednisone, you have at least 3 subspecialists, at least. And so that comment that we should have universal care for kids, it completely resonates.
Absolutely.
Siobhan, just the same as we're talking about, environment, et cetera, with the Native American or Indian American health, there is a lot of disparity. And we have a few slides on that too. I remember from the surgical aspect, we'd be like, there's a lot of gallbladder disease. Like I interviewed at Arizona. I didn't go work there, but at the University of Arizona in Phoenix. And they were talking to us about what's happening and the program. And then they said, that, by the way, and of course we learned this in med school, that there is a high rate of gallbladder disease and biliary disease in Native Americans. I'm going to flip back and forth because I think I usually say Native Americans and not Indian Americans. But anyway, there are other issues that come in terms of diabetes and heart health. And do you feel that from your perspective and your involvement that the Indian Health Service is actually making a difference?
I think they're doing the best they can. And there is a special diabetes program through the Indian Health Service, but a lot of it comes back to the land and choices that are beyond the community. So for instance, if you look at the Pima Indians, which is not what they prefer to be called, they're an Acoma tribe, but that's what you see in the literature. They have some of the highest rates of diabetes in the world. It's over 50% of adults have diabetes amongst that tribe. But part of that is that they were removed from their land and not able to live their traditional life with their traditional diet for the Hoover Dam. So you have generations eating what we call commodity foods. And if you've never heard of that, look it up because it's terrifying. But like commodity cheese is just a giant block of fatty wonderfulness that is not good for you.
I think we used to call that government cheese, right? That's government cheese.
It tastes great.
that was a staple in the lunch, that and Spam in the Lower East Side when I was growing up.
But fry bread, people think of as a native food, but it's really just making the most of commodity food. So if you have Crisco, lard, and flour and salt, what are you going to do with that? So you make fry bread. So I call it a USDA traditional food, not a native traditional food. And there's a lot of controversy over that. But again, those choices, of course, these things taste good and it feels good at the moment. And it's when you can't go back to your traditional ways, which are much healthier, that, of course, you're going to have more consequences in terms of comorbidities. So I think you can say the Indian Health Service is doing what they can. However, some of this is systemic and we need to address that.
We have a couple of slides, I think, on that. One is talking about the healthcare. This is
this is actually really a good one from Siobhan, actually.
Yeah,
sure, we can take a slight turn off the conversation. And this just came out on Friday in a paper. I was super proud to lead the team on this. But we were trying to take the dimensions of race and create questions that would allow editors, and we're imagining a diversity editor, review papers in advance for racial bias. And I have to say, of the dimensions, tone and terminology, we had to put one in there that was basically, is this paper racist? Because although we had incredible agreement over 30 years of literature in our lit search, nobody thought to say you shouldn't publish a paper that's racist. So we had to add that in.
I thought that's very interesting. And yeah, I like the flags, right? Green. Those questions are very interesting, and you don't think about it.
No, and with all that happened, especially with JAMA, the editor-in-chief, and their podcast on structural racism, which is actually a demonstration of structural racism versus how to fix it, that really showed us that
if our viewers don't know, explain, Siobhan, because some of our viewers are not in the weeds of JAMA.
Okay, so earlier this year, there was a podcast put out by two New York physicians who are not people of color, discussing structural racism in a way that basically said, don't make white people like us nervous, and let's just not talk about it. Let's talk about things like social determinants of health, because we don't like the word racism. So, and there were many layers further, but I'll just leave it at that surface problem. And what's worse is that it was counted as continuing medical education. And as a leader in the American Medical Association, and I have to tell you that there is an iron wall between the AMA and JAMA. They have editorial independence. But a lot of us were very upset by this. And it took a while. There was an independent investigation on the JAMA side by their oversight board. And eventually the editor-in-chief did leave over this. So, somewhat progress. And they're trying to fix things. And I admire that. However, I just don't, there's so many pockets of people who just are clueless. And what is published matters. These things, absolutely, the words matter. What is published matters. It all, especially for med students and early trainees, they're getting their information that they trust from the literature. And when the literature is off base and tone deaf about racism and that they are perpetuating it, then you perpetuate it. So this tool, I think, has the ability to, it's not going to work. You can't just release it into the wild and it's going to fix everything. There's going to need to be a lot of work behind it. But it's a good first step.
Siobhan, that slide, that work that you did, that paper you wrote, is that for the editors, like the associate editors that send out? Like, so for people who are listening, there's an editor-in-chief and then there are associate editors. And then it seems to me the associate editors are the one, and then there's reviewers of papers. And it always strikes me that associate editors basically call all their friends and send them, I got something for Christmas from one of my friends, like, please review this article. I'm like, okay. But so this goes through a process. So who would be using that it's a metric, I guess. Who would be using that? Is it going to be from the reviewer level, or does it get bounced to the associate editor? How do you envision? Because as you said, just having it out there isn't enough. Implementation is so key.
Well, we're still working on some of those logistics, and the next paper, we're going to actually apply the tool to an 80 article data set from JAMA, New England Journal, a Journal of Oncology, and PLOS ONE, so that we can really get a good sense of whether it works on a broad spectrum of papers. And then we started this a year and a half ago, so this is long before the JAMA controversy, and we were certain that there's going to need to be a diversity editor. And so there's an editor-in-chief, there are associate editors, and then there's really no category currently for a diversity editor, but that was one of the solutions that JAMA proposed for themselves. So I think that could really be, yes, JAMA is, the Journal of the American Medical Association. And it's like, I don't know how many journals they're up to now. It's kind of like the rabbits of journals, because there's so many more new JAMA journals.
Mhm.
But they have, like JAMA surgery is a big one. There's a
JAMA
regular
otolaryngology.
JAMA, and then
JAMA
there's
pediatrics. Yep. Just keeps going.
So,
lots of
you know,
JAMAs.
so I think this is really important. And I think as reviewers, even, we need a metric to say, does it even meet the first pass or the second pass? I think that's really very helpful. I've turned back papers and said, this is a manal. I'm sorry. This is a MAPER.
Right.
This is men's only and white men only. And you're addressing a topic that really needs more diverse input in order to make that topic actually benefit our patients, or that paper actually benefit our patients. We have, again, people watching from all over. I'm going to call out some names: Rie Bronander, Sumana Rangachar, Joe Diamond, Lori Holden, Barbara Leonardo, Erica Bleiberg, Falguni Vaidya, Jack Berajic, and Ariaga, who thanks you guys for all that you are contributing to all that we know. We have somebody called Syed Anwar, but he posted in Hindi, and I have to tell you, this Kannada-speaking girl does not read Hindi. But thank you guys for watching. Please like and share and tag and listen to us on WBAI 99.5 FM in New York and WBAI.org. We're on Mondays from 2 to 3 over there. I wanted to switch a little bit back to pediatric critical care. So Sapna, you had talked a lot about these outcomes. So can you give us a sort of a broad stroke of what happens and what we need to think about as children, thankfully, leave the pediatric intensive care unit better than when they entered, but then what happens?
Right. So yeah, and actually our concern is that, you come to the pediatric intensive care unit for whatever brought you there. And the problem is we may have taken care of the acute illness, but all of the interventions that we administered to save your life, and all of the other aspects of the stressful environment, sleep disruption, delirium, the iatrogenesis that's involved with those interventions, they have impacts that we didn't appreciate until just in the last 5 to 10 years. So this is the slide that you're seeing is an infographic from our paper in critical care medicine. We actually did a study looking at 82 intensive care units across the United States. And that study has been replicated in Europe and Brazil and Canada, and I'll bring those up in a moment. And essentially what we found is on any given day in a PICU in the US, and this represented 1/3 of all PICU beds in the United States, that only 1/3 of kids will have received PT or OT, physical therapy or occupational therapy provided mobility. And 20% of the kids are basically completely immobile. They don't move from their bed. Their head of bed doesn't come up. They don't sit in a chair. Even though the safety event rate's really low. But one thing I really want to emphasize on this slide, you see smack in the middle, you see that girls in the United States were less likely to receive therapy from a PT or OT in this very large sample size, and also younger patients. What's very important about that is that was something we only found in the United States. None of the other countries had this bias with regards to girls in the pediatric ICU. And the other potentially implicit bias that we have when we take care of patients is that patients with higher baseline function, the straight A student, star soccer player before they came to the ICU, we're less likely to get them a rehab team consult early on, probably because we're assuming they're going to be fine when they leave the hospital. But what we learn is those kids do have a high risk of significant functional decline. So the girls thing really was mind-boggling and very interesting. And the other aspects I think we might have anticipated, but really underlined now with this very big sample size, that we have a lot of work to do.
So Sapna, are girls in the ICU for different reasons than the boys are? Are there, like, what is
Nope.
wrong with us is maybe my question.
Great question.
What the heck?
It's so funny when I present that slide anywhere, in any talk, in any forum, you can just see everyone's eyes just like get really big and just a lot of head shaking because no one can wrap their head around it. And the fact that we did this study in 100 other ICUs across the world and we didn't find that disparity, like, come on, guys, like, what is up?
Right? Like, we have so many women in healthcare. The nurses predominantly are women. The PT/OT also women. Isn't that weird? Is this like an inherent bias?
I have, we need to figure it out. It was impressive, let me just say. And when, I did the initial analysis and then turned it over to the statistician. I said, please tell me I did something wrong. And I had done it right. And they confirmed it over and over and over again. So we're open to suggestions, but obviously that's why I have an intervention that is designed for every kid every day. These issues should not even come into the mix at all.
Well, it's nice that informed change for you, right? That's the idea of doing all the research, that you have things that now you can do to make a change. And it can be not that you're trying to keep writing papers, but still, that'd be a great way to look at it, to look back on the year and see what the outcomes are. It's going to be fantastic.
Yeah, no one wants to keep writing papers because then obviously that takes time away from the actual work, but that's the only way to get it to someone at a bedside somewhere who will hopefully make a change at their own bedside. I think that's why we need to disseminate our work. That's really important.
Sapna, I want to talk a little bit about, we hadn't talked about COVID before, but talking about COVID in children and what you are actually seeing, your boots on the ground and what's happening. You probably hear from your colleagues as well, what's happening with COVID in pediatric ICUs. Pediatric ICUs, for everyone, unless you're at a major center, they're usually much smaller than adult ICUs. They don't have as many beds. So, most of the ICUs have, like, in a smaller institution, will have like 2 to 4 beds, and that's it. So when you say around the country, the pediatric ICUs are overrun, it's a little bit different than the adult ICU beds, but they're still, actually a lot different in numbers, but it's still an important resource that is being overutilized at this time.
Absolutely. The numbers are going up, and I would be underestimating if I didn't say that it's scary. So, the trends, back in the day, March 2020, I can't believe we're still here talking about this, but here we are, pediatric intensivists went to the adult ICUs to help care for adults because our burden was not that high. But now, with all of the surges and the new variants, our numbers are just going up across the country. I just saw a tweet come across from Jorge Caballero that highlighted different regions of the United States and what the hospitalization numbers are for COVID in kids that came out recently from the FEMA website and the CDC, and it's alarming. There are some regions that are slowly increasing, others that are just setting records each and every day. I know in my children are teenagers in middle school and high school, and they're slowly closing down different aspects of extracurricular activities. And, we're all hoping we don't end up going all virtual again, but the numbers are rising. There's no question. And yes, children are not as likely, we're not seeing as much critical illness. However, there are the populations that cannot get vaccinated yet and aren't getting vaccines. And of course, the older kids who didn't get vaccinated for whatever reason. So it really comes back to boots on the ground, emphasizing vaccination for all the kids that we can get vaccinated, and still continuing to do the work in the younger populations. We admitted an infant with COVID in the last several months. We have multiple children and teenagers, unvaccinated teenagers who have severe COVID-19 illness. So the burden is rising.
It's a jarring statistic. We understand that children under the age of 5 cannot be vaccinated, but children 5 and over in the United States can. And we really do encourage vaccination. Marina and I were talking earlier about myocarditis or heart inflammation after vaccines. The number is so low compared to the severity of heart inflammation in young men, especially young boys and men who get COVID. So please vaccinate your kids. I want to do a little shout out to my friend Joe Diamond, the Jewish cardiologist from Roslyn, New York, who wrote in Kannada, Sujana Hegidya Shubhashayagalu, which means, Sujana, how are you? And
Yay, Joseph.
best wishes. Go, Joe. You have two Kannadigas. You should have written Sapna as well. So, Siobhan, I wonder if there is a complication in especially smaller communities of Native Americans or Native Indians where the children grow up and leave, and maybe there's an older population. Are you seeing some discrepancies in how the communities are able to band together when pieces of the community leave, and how that's being addressed?
Well, I think according to the last census, Native Americans or American Indians, Alaska Natives actually are a very young population. And there is a bit of trouble capturing rural versus urban, getting some of that, what you're talking about in terms of traditional lands or reservations versus leaving for opportunities. And it's hard because a lot of people will travel from one place to the other depending on the time of the year. So when the census worker actually showed up or when they actually filled out the survey, it could be very different than a different part of the year. So I take all of that data with a little bit of a grain of salt. I think there is certainly difficulty filling key positions in healthcare for the Indian Health Service or tribes that are in more rural areas. And that's very typical of rural areas as well. Just difficulty getting care. However, we're doing the best we can, and I would just take all of the data with a grain of salt.
So Siobhan, and then Sapna, we are running out of time. This has been a fast hour, and we've been so thrilled to be able to talk with you. Let's start with Siobhan. You have any takeaways for our viewers?
Absolutely. I think my main takeaway is that don't deny racism. Even if it makes you uncomfortable, just say, well, that's not been my experience. Please help me understand. I think that's a key thing, because even the tweet that was sent out by the said, when I was in preschool, I was insulted. They actually beat me up. So these are real physical manifestations, and it's okay to be uncomfortable, but also don't shy away from those issues. And then I think even though there is an Indian Health Service and that is providing care, it is not providing care for everyone who identifies as American Indian, Native American, Indigenous, tribal, not from India, Indian, however you want to put it. But that's not, they don't have a blank check. There's only so much funding. So, there's really a lot more coordination that could happen. And pre-pandemic, I wrote a piece on the argument for teledermatology with natives, because it's an average of 68 miles between a rural clinic that's run by the Indian Health Service and a dermatologist's office in the US. So, there's lots of ways that we can be more creative, but just don't think that because there's an Indian Health Service that the Indians are taken care of, because that's not the case.
It's not the case. They have to get people there, and they have to have staff, et cetera. And it's hard to staff that many times. Sapna, your takeaways?
My takeaway is, number one, there's actually a hashtag for it. It's put kids first. Bottom line, I know it sounds really cliche, but kids are the future. They are what is going to create our world in decades to come, and what it's going to look like. And if we don't invest in them from the get-go, from a preventative health perspective, all the way through, that's really where it's at. So put kids first. Let's all work together to optimize outcomes for kids, whether they're healthy or are impacted by critical illness. The second take home is to lead by example. There are so many small things that we do in healthcare that if we talk about why we made a decision we did, it can have a huge impact on the larger medical community and all of our interprofessional teams. So, when I'm on rounds, I really make an effort to talk about why I specifically took time out to make sure that this child was held by their mother for the first time after being in the ICU for a month. Things like that I think we never understand how much impact our words can have, and how much each of us can have an impact by leading by example. And then my final take home is less is more. There's, I work in an ICU where invasive interventions are really central to everything we do. However, it's the little things that often matter most. And often, as my surgical colleagues here know, sometimes the best decision you can make is not to have an intervention. And, sleep hygiene, optimizing family engagement, making sure we minimize, sedative medications, optimize communication, all those things, they're not sexy, they're not high tech, but they can have a very long-term impact on kids and adults who have hopefully very long lives to live. So that's my final.
Thank you, Sapna and Siobhan. Thank you guys, both of you, so much. We are so happy that you joined us. It's like meeting new friends, and it's very exciting for us. We also love our viewers. We love your comments and your salutes to us. This is our last show of 2021, and we've had 59 shows, 116 guests, and you can see almost 130,000 social views. We're glad that we're getting the message to you guys.
So be safe, wear a mask, get vaccinated, get boosted. Merry Christmas, Happy New Year. I love working with you, Marina.
I love you. Bye, guys.